Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, good afternoon. I'm Susan Kaufman. I'm here for Attitude's weekly ADHD Experts broadcast. And today we'll be talking to Dr. David Anderson of the New York-based Child Mind Institute about the ADHD-ODD Connection. Research shows that a significant percentage of children with ADHD meet the criteria for diagnosis of oppositional defiant disorder, ODD, which is a very closely related mental health disorder. It's characterized by behavior problems, and it's often diagnosed in early childhood. ADHD and ODD are both associated with lots of stigma. They're both ones that parents find very difficult to understand and to really be sure about their child's diagnosis, about how to find the right intervention and how to support their child at home and at school. Dr. Anderson will be talking about all of that, including the differences between ADHD and ODD, as well as the genetic and the environmental links to ADD and ODD and how they can affect treatment approaches. He's going to be addressing the framework for support for a child with ODD and immediate practical strategies that parents and educators can put into effect to improve a child's behavior. So should be a great session. Let me introduce Dr. Anderson to you. We're so thrilled to have him. He is a senior director of the ADHD and Behavior Disorders Center and a senior director of national programs and outreach at the Child Mind Institute. If you don't know the Child Mind Institute, it is a wonderful organization. They have a great website, and I really urge you to try to log on. Dr. Anderson specializes in evaluating and treating children and adolescents with ADHD with behavior, anxiety, and mood disorders. He's an expert in behavioral parent training, in school-based consultation, and cognitive behavior therapy. He lectures all over the country. He's just on his way to San Francisco for a full week of lectures, leads workshops for policymakers, for parents, and educators. So we're just really fortunate to have him with us today, and I thank you for your time, Dr. Anderson. And I want to thank the sponsor of our webinar today, which is an interesting new product called Revive Connect. It is a wristwatch. It's been funded by the U.S. Department of Education, and it aims to improve focus and attention through gentle vibration reminders. So check out revivetech.com for more information about Revive. We are grateful to our sponsors always for allowing us to give our webinars at no cost to anyone. So thank you, Revive, and for Dr. Anderson.
Great. Thank you for giving me the opportunity to present to anyone who might be listening and anyone who's going to watch this on recording afterwards. So again, we're talking about ADHD and ODD, just to give a sense of the outline of the presentation today. So I'm going to put it in kind of four parts. First, I'm going to talk about how ADHD and ODD are diagnosed, the symptoms, how you do a diagnostic assessment, and what kinds of things you have to look out for in diagnosing either of these conditions that may better explain symptoms that kind of masquerade to look like ADHD or ODD. In the second portion, I'm going to talk about just a few genetic, environmental, and developmental considerations associated with ADHD and ODD. In the third portion, I'm going to talk about what effective treatment looks like. So I'll do a quick review of kind of the most updated literature on treatment for ADHD and treatment for ODD, then kind of zero in on what mainly behavioral parent training and school consultation approaches look like for these disorders. And then I'll get into a few of the kind of starter concepts for interventions. Some of the basic principles underlying behavioral parent training, some of the thinking around how you start behavioral approaches, and then also a few things about the kind of interplay between the relationship and a behavioral approach. So, first part of these slides is going to be about differential diagnosis for ADHD and ODD. So I realize one of the issues with some of these slides is they're going to be better on printing out, just because there is a lot of information on each slide, and I have a tendency to make very busy kind of presentations. But for those of you who can see each of the letters on this slide, on the left column, I have ADHD symptoms, trademark ADHD symptoms out of the DSM-5. In the right column, I have oppositional defiant disorder symptoms, or ODD symptoms. One of the ways that I've grouped the symptoms is in terms of symptom clusters. So for ADHD, on the left, in order to get a diagnosis of ADHD, you have to have at least 6 of 9 inattentive symptoms, and the inattentive symptoms are listed in the top cluster. inattention, distractibility, making careless errors, difficulty organizing tasks, avoiding tasks that require a lot of sustained attention or effort. You have to have six of 9 of those symptoms, or, I should say, or 6 of 9 of the hyperactive impulsive symptoms, which are in the second cluster. Fidgeting, difficulty remaining seated, interrupting or blurting out answers, always being on the go, having difficulty waiting one's turn. These are the symptoms of ADHD. And the thing is, there are 3 different presentations of ADHD. So just to be clear, in the DSM-5, the term ADD does not exist. What you have is ADHD inattentive presentation, you have ADHD hyperactive impulsive presentation, and you have ADHD combined presentation. So you have these presentations of symptoms which signify whether or not the inattentive symptoms are more prominent, whether or not the hyperactive impulsive symptoms are more prominent, or whether a child actually has 6 out of 9 of both clusters, which is the combined presentation. The reason why we call them presentations is in the most recent update to the DSM-5 in 2013, it was found that while ADHD is a reliable diagnosis across development, the presentation of symptoms may not be as reliable. So rather than call it a subtype, and decrease parent or educator confidence if that subtype changes, you call it presentation so that everyone knows it's still the umbrella category of ADHD, but just like with a medical diagnosis, you may get different symptoms of the same thing that present at different stages of development. Another major criteria for diagnosing ADHD is that symptoms must be present in multiple settings. ADHD is hypothesized as a biological disorder, meaning that if it has such loading in biology and genetics and kind of brain-based functioning, we should see it across settings. It shouldn't be dependent on any particular environment, meaning that responsible diagnosis of ADHD involves establishing that the symptoms are present across school and home settings. Now, to move to the oppositional defiant symptoms, the first cluster is more about kind of a child's emotional kind of temperament and the fact that they may lose their temper, be annoyed by others, or be angry and resentful. The second cluster is more about how that emotional temperament gets expressed. They're arguing with people in authority, actively defying requests or rules, deliberately annoying others or blaming others. These 2 clusters, you're not required to have all the symptoms in the cluster. For ODD, you need 4 of them. But the major thing is where, with ADHD, you're looking for symptoms that are present prior to age 12 and across multiple settings. And I will say it's not a requirement that the symptoms be present before age 12 for ADHD. But even though you're looking for symptoms across multiple settings, ODD has a particularly stringent duration criteria, which means that the symptoms should be present for at least 6 months. They've become fairly embedded as a way that the child is functioning. Now, we see many patients for whom the symptoms have not been presenting for 6 months or more. It may not necessarily mean the child doesn't need treatment. I'll phrase that in the positive. The child still may need treatment. But at the same time, to get the diagnosis of ODD, we really should establish the symptoms are very persistent and they've been in place for a while. There are considerations with ODD for mild, moderate, and severe symptoms, and they're based on a number of settings. So if you express the oppositional defiant disorder symptoms perhaps only in a family setting or one setting, your symptoms might be mild. If your symptoms are in 2 settings, say with family or at school, it might be moderate, and severe might be across multiple, say at sports practice, at school, and at home. There are also considerations for under 5 and over 5 years of age with ODD, and this is in line with the research in the sense that kids who present under 5 may have more of a biological basis for the disorder, whereas kids who present past age 5, it may be emerging partly due to environmental conditions, something related to family conflict or certain settings. Importantly, there's also another acronym that we think about with any mental health symptoms, ADHD or ODD, and that is FIDI. It's frequency, intensity, duration, and impairment. So when we think about any sort of mental health diagnosis, we want to establish, are the symptoms frequent? Are they occurring with such intensity that they require kind of treatment or support? Have they occurred for sufficient duration to satisfy diagnostic criteria? And do they cause such impairment for the child that the child cannot function without getting some level of support or evidence-based care? So, moving forward, It's important to get a high-quality diagnostic assessment for ADHD or ODD. Now, what that means, I'm going to outline on the next slide. But what's important in diagnostic assessment is that because there are no objective diagnostic tests for ADHD or for ODD. Now, what I mean by that is there are no blood tests. There are not, at this stage, brain scans or research-based medical tests that can actually confirm the diagnosis. Now, there are neuropsychological tests that can provide supporting evidence. That's definitely out there. But if someone is advertising they have a medical test for ADHD or ODD, that science we do not believe exists just yet. There's not as much scientific support as we need. So for that reason, it requires a clinician who's going to do a very thorough evaluation, take stock of all factors that might be involved, and make sure not only to rule in ADHD or ODD as a diagnosis, but also ensure that they're ruling out anything else which might be responsible for the symptom presentation. So, for example, parents can come in and be saying that their child's having difficulties with attention or their child's having difficulties with behavior. In terms of the things that we want to rule out, children who are having sleep problems, who may not be getting a full night of sleep, who are waking up in the middle of the night frequently or having problems with breathing while they're sleeping. For anyone who's not sleeping well, we all know this can affect your behavior during your waking hours. We want to make sure that we're ruling out that or any other medical causes, one of which might be head trauma, in the sense that for people who've gotten a head injury, depending on the kind of severity of that head injury and their medical status afterwards, there can be reasons why you see behavior or attentional changes. We want to make sure that we're understanding if there are any medical rule outs for these symptoms. Similarly, we want to be cautious related to other mental health disorders. Depression has as one of its symptoms that you may have difficulties with focus, and mood disorders similarly. With anxiety disorders, we may see children who are so anxious that in class they have difficulty focusing because they're so worried about a particular thing or an upcoming test or performance anxiety or social anxiety. And we don't want to overinterpret their difficulties with distractibility because they may just be anxious. We also want to be cautious in thinking about the overlap between ADHD and autism spectrum disorders. In fact, in the version of the DSM that existed prior to 2013, there were many qualifiers about avoiding diagnosing a child with an autism spectrum disorder and ADHD at the same time, partly because there were so many overlapping ways that those symptoms could be credited to either disorder when in fact they might be better explained by just one disorder. Children who have early speech language difficulties may also act out behaviorally. Partly we hypothesize because they have difficulties communicating their needs, preferences, or communicating effectively with peers, teachers, or parents, and for that reason could act out behaviorally. Children with learning disorders, we want to rule this out because if we have a child or a teenager who, for example, is acting out in only one subject in school or who is avoiding one particular academic activity during homework or during the school day, that may be because they actually have a learning problem in that area and not because the ADHD or behavioral symptoms that are being reported necessarily extend to all other subjects or portions of the school day or something like that. Finally, we want to think about post-traumatic stress because as part of post-traumatic stress disorder, someone may have difficulty focusing in situations where either they're re-experiencing reminders of a particular traumatic situation or in situations where they feel kind of hypervigilant or that they can't seem to relax. And again, this is why we want to make sure that diagnostically we really do our due diligence. In thinking about that, here's the last slide on diagnosis. It's that in doing an effective diagnostic evaluation for ADHD and for ODD, we want to start with a diagnostic interview. Now, this means going through basic symptom criteria for pretty much everything that might present during childhood and adolescence. In my practice, we use a semi-structured interview called the KSADS. Others may use other interviews, but we try to go through every disorder in order to make sure we ask parents certain screening questions to rule in or out certain diagnoses. Now, for the child interview portion of that, depending on how old the child is. If they're a teenager, we may put more stock in what they might be able to report. If they're a child, we might try to adapt the interview only to areas that parents isolated as troublesome, and try to ask the child a few developmentally appropriate questions related to what they might experience of their symptoms. As part of an evidence-based assessment, we also may do a class observation or an observation of the child with the parent to look at both the parent's strategies for managing the child's symptoms and the child's symptoms in kind of a real-world interaction. We'll also get reports from teachers, both qualitative, meaning that they write to us about what the child might be experiencing in class, and symptom questionnaires from both parents and teachers, and really anyone else who we think has a good sense of the child's presenting symptoms. Those symptom questionnaires are often general. Like we might use something like the child behavior checklist to just get a sense of any symptoms that might be presenting. And then we might also focus in on an ADHD or an oppositional defiant specific symptom questionnaire like the Conners or the ECB or the CESP to get a sense of a child's symptoms in a particular home or school environment. Finally, we may use supporting evidence from psychoeducational testing or neuropsychological testing to inform whether or not we feel a diagnosis is present, or it might be better explained by any of the things that I listed on the last slide. Now, the reason why we take this approach with assessment is to get reports from as many informants as possible, to get as much of a comprehensive picture of the child or teen's behavior, and to make sure that we really get a sense of whether or not these symptoms are presenting across settings or just in one setting. We don't want to take only one person's report as gospel. In terms of what we consider with caution, we consider with caution prolonged observation of the child. It's been shown in the research this may not necessarily reliably indicate the presence or absence of one of these diagnoses. So for that reason, if we're told by a teacher or a parent, I want you to come in and observe this child for a very long time, oftentimes we might do that and find that over the course of that time, a teacher or a parent says they actually didn't present with any of the stuff I wanted you to see. Rest assured, in many cases, the clinicians have seen what you want them to see in other children or teenagers. We consider with caution a child or teen self-report because a child or a teenager may have many reasons why in an intake evaluation they want to convince you of their particular perspective on these symptoms. So for that reason, we want to at least speak to a child or a teenager about their symptoms, but we don't necessarily take what they're saying as the absolute truth. And finally, I've already kind of identified it, but we want to consider with caution any claims related to specific medical tests. At this stage, ADHD and ODD diagnosis is more dependent on the thorough approach of a clinician than on any objective test. So next, I'm going to move into genetic, environmental, and developmental considerations. There are only 2 slides on this, but I think there are some important points that we should talk about in this particular area. So for this first slide, one of the things that I've already emphasized is that we consider ADHD, based on the research, to be a highly heritable condition, meaning that if a child or a teenager has ADHD, it is also very likely that a close relative may have some symptoms like ADHD, or that a sibling may have symptoms like this, just because of the high genetic loading. ODD also has genetic loading as well, but within the research literature, there is more in terms of considerations related to environmental factors that might lead to behavioral problems with temper or defiance or argumentativeness. One thing that's interesting about the genetic research is that there is a body of literature linking ADHD and ODD to a common genetic, what we call externalizing factor. So externalizing is a term that's applied to behavior disorders like ADHD, or ADHD is a neurobehavioral disorder, but it is a factor that is, externalizing is a term that's associated with disorders that have symptoms that likely involve kind of the expression of those symptoms with others or toward others, whereas internalizing is a word that is often assigned to diagnoses like depression or anxiety that are thought of as being experienced internally and may not be as obvious to others. But in this sense, that common genetic externalizing factor may be one of the reasons for the high rate of comorbidity I highlight at the end of this slide. One interesting piece related to genetic research as well is that some genes in ADHD, implicated in ADHD, suggest a sensitivity to adverse environments. And this goes along with something called differential susceptibility theory. So it's this idea that you may be biologically loaded for ADHD, but then depending on what environment you're placed in, those symptoms may become more prominent or less prominent. And that plays a large role in us thinking about how we make the environment fertile for a kid with ADHD to succeed. Finally, I've kind of already highlighted the point about ODD, where it's early emerging, likely being hypothesized as more genetic, whereas expression of ODD later in childhood or adolescence may be more environmentally induced. The final piece of this slide, I just get into prevalence statistics. It's that across the research literature, ADHD is hypothesized to be something that occurs in about 8 to 12% of the population, whereas ODD is hypothesized to occur, at least in the developmental research, in about 5% of the population. So a lesser percentage than ADHD. And at the same time, you can find studies that have ranges both above and below those numbers, but that's kind of where we place it, at least in the consensus within the research. Now, the estimated comorbidity is the really interesting thing here, which is that ADHD and ODD in the research literature range from 40 to 60% comorbidity. Now, comorbidity is a fancy diagnostic word for co-occurring. In other words, if you have ADHD, there's about a 40 to 60% chance that you may be diagnosed with ODD at some point in your development as well, which means it's really important for us to consider both these diagnoses as separate diagnoses and how we approach them in terms of treatment, as well as together, since they so frequently co-occur. And the thing is, in terms of psychosocial treatments, which psychosocial being the treatments that are not medical or don't involve medication, the approach is actually quite similar. So, which we'll talk about in kind of future slides. So this slide, again, is one of those that is fairly busy, but it's just a few developmental factors to consider in ADHD and ODD. So when looking at this, I have on the left factors in a child's developmental trajectory. Now, many of these are related more to the ODD literature than to the ADHD literature, because as I previously stated, ADHD is considered to be the more biologically loaded condition. But in terms of factors that may put a child at risk for significant behavioral difficulties later on, whether they have or don't have ADHD, one of them is a reactive temperament, which is a particular characteristic of infants and kind of on into early toddlerhood, in which an infant may be difficult to soothe, highly reactive to environmental stimuli. Even when a parent is present or trying to soothe the child, they may still have a kind of hyperbolic reaction to what's going on in their environment. Another factor that's been highlighted in the literature is callous unemotional traits. Now, it's very common for parents of children or teenagers who have ADHD or ODD symptoms to say that they don't see empathy, or they don't see consideration for others, they don't see taking responsibility for actions. That is still in line with the common symptomatology. Callous and emotional traits are a step even above that in terms of a child's consideration for others and their kind of insight into their social world and their ability to consider the impact of their actions. And these traits, when they're present, they implicate an even more kind of significant or negative kind of developmental trajectory, where without treatment, things could get very difficult very quickly. Another developmental factor is a tendency toward novelty seeking. Now, that one is very frequent in ADHD, especially in the hyperactive impulsive symptom cluster. And when you are novelty seeking, what this means is that you may not have a tendency to engage in play or activities that are within the bounds of, say, what would be appropriate in a preschool or early elementary school classroom. You're looking for whatever's new and whatever's around the next bend, which, even though you may be without malice in terms of your intent in seeking out novelty, it's often interpreted by the adults in your environment as a lack of respect for rules or a tendency to disregard what adults are asking you to do. Again, related to ODD, another developmental factor is higher aggression earlier in development. Another factor is attribution of hostile intentions. So when you're in a social situation, another kid throws a ball and it accidentally hits your child in the face, their thought is, they meant to do it, they meant to hurt me, I have to retaliate, I have to get revenge. those kinds of attributions early on in development can be very predictive of later behavioral difficulties. And finally, difficulties with processing social details. This is true of ADHD and ODD. It's that where other kids might see what's going on in their social milieu, a child who might be prone to ADHD or ODD may miss those details and thereby decrease the chance they're going to make prolonged friendships or solid friendships or sustainable friendships, and may also make it so that they're perceived as not following the rules of games or not engaging socially in an appropriate manner. In terms of environmental or family factors, harsh or inconsistent discipline has been associated with both the exacerbation of ADHD symptoms and the emergence of ODD symptoms. A lack of supervision, both in children and teenagers, is associated with the exacerbation of symptoms. Low warmth within a family, in other words, a high level of tension, a sense that everybody is kind of at their wits' end or at each other's throats in terms of high family conflict, can be very predictive of the exacerbation of symptoms. Just going back, by the way, to a point on harsh and inconsistent discipline, those are two different things that we try to help families to engage in. One is to decrease harsh discipline, because there's a tendency in all of us to think the bigger the punishment, the bigger the effect, which is just not true. And with inconsistent discipline, it's not so much that you're yelling at a child or telling them their behavior is off limits consistently. It's more about the consistent application of a consequence that is appropriate to what your child is engaging in and happens every time a behavior of interest is presented, which we'll talk about a little bit later. Going back to these few factors, parent substance abuse and mental health disorders. Obviously, if a parent is having a battle related to their own mental health, it can be difficult to effectively parent, care for, or support a child or teenager with ADHD or ODD. Child abuse or neglect is predictive of both of these conditions. Early on in development, pretty much any time that it occurs in terms of its emergence. And it makes sense because at some level, this is a loss of faith that the world is just and that you should listen to your caregivers. And then peer group deviance is a kind of later developmental factor, particularly associated with ODD. In the sense that if you have failed in school or you've been rejected by your family and your peer group is engaging in deviant behavior, that can be a real kind of facilitator of a child's own deviant behavior. In terms of possible developmental effects, I just listed a few of the major ones in the research right here, which is that ADHD is linked to academic failure, peer and social problems, increased risk of substance abuse, and unemployment. And these are some of the major developmental effects, I should say, for untreated ADHD in particular. And then for ODD, there's the possibility of progression to an even more severe condition called conduct disorder, and an even more severe condition beyond that called antisocial personality disorder, and increased risk of substance abuse, delinquency and criminal behavior, police contact, and possible arrests or incarceration. And all of those things are things we want to prevent through what I'm about to move into in terms of a phase presentation in terms of effective treatment. So just because I'm running a little bit long on these initial slides, I'm going to try to spend a little bit less time on the effective treatment slides, partly because they're research articles that I've included citations for at the bottom and that can be found fairly easily. And I know that folks said practical strategies were one of the major things they wanted me to focus on. So in terms of looking at the research, this particular figure is taken from the most recent evidence-based summary of psychosocial interventions for ADHD, meaning non-medication interventions, and where the evidence base is strong and where it might be weak for certain interventions. And this is Steve Evans and colleagues, Julie Owens and others who published this article in 2017. So importantly, the approaches that are evidence-based for ADHD involve medication and the application of behavioral training interventions, mainly training parents alone, training teachers alone, and then having them apply the strategies, training the adults in a child's world to help them to engage in appropriate behaviors in the school and peer settings, organizational training, and then kind of combined interventions that involve the child as well in terms of coaching a parent or teacher with the child present. This is the highest evidence base. Now, importantly, when we look at this particular summary table, there are qualifications for the age group that something is effective with. So, for example, training a parent and either coaching them with their child or coaching them in the application of behavioral strategies at home has a P and an E next to it, meaning it's most effective for preschool and elementary school populations. Same thing with behavioral classroom management and behavioral peer interventions. Organizational training has been shown for late elementary populations as well as adolescents. And what you'll notice is that many adolescent approaches, and this is part of the status literature on both ADHD and ODD, approaches for managing the behavior of adolescents have fewer studies associated, require even more research to look at effective approaches, tend to be kind of multi-systemic in that they work with parents, they work with teachers, they work with the family, they work with the adolescent as well, all on teaching strategies to solve problems, manage symptoms, and effectively manage contingencies for behavior. When we talk about the most effective approach for ADHD, the most effective treatment approach is combined medication and psychosocial intervention. Now, if you engage, for example, with an elementary schooler in either medication or behavioral parent training and teacher consultation, either approach can be effective, and the research supports that. Bill Pelham has research coming out of Florida International and out of Buffalo that shows that if you sequence the interventions, it may be more effective to start with behavioral interventions and then move to medication at a later date rather than the other way around for a host of reasons. But to be sure, the combined approach still demonstrates superiority in the research. What I'll emphasize as well for ADHD is that there's a need to work across settings. As Barkley would say in his research, there's a need to intervene at the point of performance. You cannot in an office just talk to a kid with ADHD about where you'd like them to focus their efforts and then hope that they will focus their efforts wherever you tell them to. It's important that the adults in the environment are trained in the interventions and ready to apply them where the child or the adolescent is actually performing. Finally, one thing to note about this table is that physical activity, omega-3 or 6 supplements, and social skills training are all on the bottom level with questionable efficacy. That means that at this stage, research does not support their use as a treatment for ADHD. And this does not mean that there aren't health benefits or that there isn't reason to engage in some way in things like social skills training. It's just that, unfortunately, for targeting the symptoms of ADHD, these interventions have not been shown to be effective thus far with multiple research studies and a robust level of evidence. Now, for ODD, this particular table that I've included is drawn from the most recent summary article by Kaminsky and Clausen in 2017 for children. Now, the most recent summary articles for ODD have been divided into one article on children and the approaches for ODD with kids under age 12, and then one article, I believe the first author is McCart, for children over age 12 or adolescents, partly because there is less research on effective approaches for behavioral problems in adolescents. But what this article does is summarize that behavioral parent training models, either delivered to parents in groups or with a child present, or without the child in the room but focusing on application at home, are the most effective approaches for oppositional defiant disorder. So looking at what those approaches look like. In terms of the course and delivery of behavioral parent training, if you're working with a child with ADHD or a child with ODD, it can be difficult to convince any parent that the best approach is to work with the adults in that child's life rather than bringing the child in for a good talk. This is not to say that we don't meet with a child during the kind of assessment phase, or that we don't perhaps have a session with a child to explain what's going on in their family or explain the course of treatment we're about to embark upon. But for most of these treatments, the child is either in a group on their own, working on social skills, which is the case with Incredible Years, or the child is involved only when the parent is being coached related to the child's behavioral symptoms, as in parent-child interaction therapy, or in parent management training, the Kasdan model, the child may not actually be involved in sessions at all, and it may be focused on the application of strategies at home. Now, with behavioral parent training, research shows that this approach can be effective in as few as 8 sessions, often about 12, which means if you're doing weekly treatment, this is about 2 to 3 months, and up to 20 sessions, which may move into kind of the maintenance phase of treatment. So in order to get effectiveness, this means that we're seeing on symptom reports by parents or teachers that when you start treatment, symptoms may be in the clinical range, and when you end treatment, symptoms are decreased significantly, and that parents and teachers are reporting an improvement in symptoms, hopefully near the level of the child's peers. Standard delivery of behavioral parent training is either with parents alone, again, coaching the parents with child, and with groups. There are also research studies on alternate delivery methods involving delivery in the home, delivery in office, but with phone follow-up, coaching a parent during the week on the application of strategies via phone. And then there's also research, at least emerging over the last few years, into intensive models, meaning delivering behavioral parent training more than once weekly, or possibly delivering a curriculum in a very large dose at once. In terms of major session activities during behavioral parent training, sessions often go in a predictable sequence. You review skills and homework that you were practicing over the week, stressors or other family factors that got in the way. There's a didactic portion in which the therapist teaches a new skill and discusses it. And there's a moment to either role play that skill, or there's a portion of the session in which we may bring the child in and coach the parent with the child. And then finally, there's a review and a plan for application at home. When we consult with teachers, it's very similar. It may be that we hear about the difficulties a teacher is having. We develop a certain plan or skills that we're going to approach problem behaviors with, and then we develop a way of tracking the data within a school setting, and we plan to apply that and come back, review the data and where it is, and tweak our strategies as we move forward. In terms of examples of models, I've just listed on the left here a number of the different evidence-based models one might hear about, and they're also cited, for example, in that summary article on treatments for ODD. These include parent-child interaction therapy, or PCIT, Incredible Years, or IY, Positive Parenting Program, or Triple P, Helping the Non-Compliant Child, parent management training, which the Kasdan model is called PMT. There is also an Oregon model called PMT-O. And I should say a note on evidence-based approaches, not all models are created equal. The last model is defiant children or defiant teens, but not all models are created equal. Not all models have the same strength of research evidence. For example, of this group, what the literature shows is that parent management training, the Oregon model, is the one that has been the most studied and shown to be the most robust in terms of the evidence base behind it. Doesn't mean it's the best, just has the most research basis. The other piece that I've summarized on the right is that in behavioral parent training programs with the largest effect, particularly for younger children, this is summarized through another article by Kaminsky and colleagues. The effects that or the components that are seen in the programs that have largest effect are increasing positive parent-child interactions. So in other words, decreasing high conflict, increasing the quality of attachment between parent and child, and the ability to communicate effectively. Teaching time out and how to set boundaries. Again, that's something that applies mainly to younger children, but the importance of parental consistency is the other point that applies at all age ranges. And then finally, requiring in-session practice of the parenting skills of the child. And again, that's something that relates to the robust nature of evidence with models like parent-child interaction therapy, or PCIT, which require parents to practice the skills with children younger than age 7 in session. So now I'm going to get into the strategies for intervention for the last 10 minutes I'll be talking here. So when we talk about strategies for intervention, I've included a few slides, and these are 4 of them, that form the basis of some of the initial discussions within behavioral parent training, or the major kind of psychosocial approach for both ADHD and ODD. So the first slide is some of the points that we psychoeducate parents on, and psychoeducate is just a fancy word for psychological education, related to the quality of relationship. Many behavioral parent training programs start off by helping to dissuade parents from myths that cognitive behavioral or behavioral approaches are robotic, that they're not tailored to families, and that they don't have the relationship as their basis. Many behavioral parent training programs came out of labs, places around the country that were studying attachment, studying a quality of interaction between parents and children, and trying to figure out how do you, in the shortest dose and time possible, restore positive interactional patterns to parents and children, because that's really what good behavior management is based on. As I say on the second to last bullet point on this slide, when we look at parenting styles, which is Diana Baumrein's parenting styles, when we look at what we're trying to do, we're not trying to overcompensate with a ton of structure or coerciveness in our parenting. We're not trying to be permissive and only nurture a child, but rather we're trying to find a balance between nurture and structure. We're trying to figure out how can we make it so our baseline is a positive quality of interaction that forms the basis of quality attachment to our child and a sense that nurturance is our kind of fallback. And then how do we set appropriate boundaries when we need to and put in structure and guardrails that are going to help a child to know what appropriate behavior looks like? So these relationship building blocks we review with parents. We review the concept of being present in many of these approaches and engaging with your child in non-judgmental quality time, meaning trying to set aside a certain portion of time per day to engage in activities that either the child likes or that you and the child like doing together, or you and the teenager like doing together. Even Defiant Teens has an inventory that you do at the start of treatment that involves figuring out what your teen likes doing and how you can start spending some more quality time just non-judgmentally engaging that activity with them. And what we mean by non-judgmentally is we mean trying to decrease the number of commands or instructions you give to the child during that time, trying not to ask a ton of leading questions that get at what you would like to see from them as a parent, and trying not to criticize them. And some parents will ask, well, what do I replace my speech with then? And the answer is you try to think about how you can look at your environment or what activity you're doing and give each other positive feedback on what you're engaging in, how you can engage in conversation where you validate and reflect what each other is saying and kind of engage in active listening. And you also try to figure out how you can engage in shared fascination or interest in talking about whatever it is you see in front of you or whatever it is you're doing. We talk to parents a lot about how being available and providing emotional support, again, is something that, as we put it kind of colloquially, fills the piggy bank of attachment that a child or a teenager needs that reminds them you're there for them. And it isn't just about their behavior, just about them, kind of abiding by what you would like them to do. We talk to parents a lot about keeping themselves regulated in stressful situations, and that from their regulation and their modeling of behavior are the cues that their child or teen takes about how to handle stressful situations. In that sense, we're not saying to parents they always have to be perfect at staying emotionally regulated or modeling only perfect behavior, but we engage parents in a lot of reflective tasks about what their behavior might be communicating to their child or teenager about what's okay, even as their words convey something different. We want parents to also stay informed about typical behavior for developmental stage, because one of the things that was, I think, humorously said at a conference that I recently attended was that behavioral parent training is as much about teaching parents and teachers and adults in a child's life skills for intervention as it is about adjusting expectations, making it so that we don't expect that just because we engage in intervention or just because we tell a child or a teenager to do something, that their symptoms won't get in the way, or that something else might get in the way, or that it's totally, something that every other child their age might be doing. And finally, we talk to parents about cultivating common interests in relationship rituals, meaning that if you have something that is a fallback, where if you're trying to increase the amount of non-judgmental quality time you have with your child, if you're remembering that Pizza Hut is a restaurant that you both like, and that whenever you go there, some worries just fade away, that's an example of a recent relationship ritual I talked about with a parent that they said, this is a moment when I think we can decrease conflict and perhaps have a chance at problem solving a little bit together. And this was with a 13-year-old boy. Now, the next slide. This is what we introduced to parents at the beginning of behavioral parent training as the major hierarchy and underlying principles of almost every behavioral parent training model. It is that what we are trying to think about for almost any behavior is that even though we as humans have a natural tendency to say, if we see a behavior, what do I do to punish it, to make it so it never presents itself again, or I never have to worry about it again? That particular impulse, while it may work with a large majority of kids who do not have ADHD or behavioral problems, it does not work with this particular diagnostic population, partly because kids with ADHD or oppositional defiant disorder can become overly habituated to punishment. It doesn't seem to do anything or change behavior. They have a tendency toward novelty seeking and a much higher sensitivity to reward, which means that they may actually be more likely to respond to positive behavioral interventions. And at the same time, there's just the fact that when you are criticized frequently, adults around you often become like either the Charlie Brown teacher, or it becomes something where if you know that you can't get positive attention, kids are often indiscriminate in the sense that they'll just take whatever attention they can get. So in this sense, we try to help parents, teachers, and any adult who is trying to manage a child's behavior think through the following steps. If you have a negative behavior, like for example, we might think about it as being either that the child is having difficulty getting ready for school in the morning, or a common teacher behavior might be a child is calling out in class. When that behavior happens, we start with just the first thing is, what are your expectations? What are you trying to do? We try to make sure with any parent or teacher that the expectations are realistic and the expectations represent a just noticeable difference or an area of growth for the child. So we usually take a data-driven approach here. We say, look, how often does the child satisfy all your expectations? If they don't satisfy all your expectations in a certain situation, one of the metaphors we'll often use, or one of the comparisons, is the idea that if you're just learning how to play baseball and you're only hitting off a tee, you don't ask a kid to just suddenly hit a 9-mile-per-hour fastball. Even if every other kid their age is able to do it, you've got to shape them up to it. So first, we try to manage expectations related to where the child's baseline is, and then where the next just noticeable difference is that we can shape them toward. This can be infuriating or frustrating to some parents because the sense is, we've done this thousands of times, why aren't they just doing it? But it is a principle of behavior management that works for all humans and needs to be applied for children as well as adults. So we start with those expectations, how we can model the behavior we'd like to see, and how we can set those expectations just beyond what the child's currently capable of. And then we just keep adjusting that with the behavioral tools that fall below this first bullet point. The next bullet point is the frequent reinforcement of positive behavior. In behavioral parent training, we teach parents and teachers and any other adult in a child's life how to effectively give positive feedback around behavior, how to effectively think of their attention as a way to give attention to positive behavior and to judiciously use it to only give attention to the behaviors that you like and try to minimize the amount of attention to behaviors that are there just for attention or just to get a rise out of people, or where the behavior may be maintained the more attention it gets. And also how to use privileges that a child may earn, or kind of constraints of a teenager's life as levers to help reinforce positive behavior. So an example with a child may be that if they finish their morning routine in a timely fashion and while also staying calm, they may earn points toward earning screen time on a weekend, or they may earn points toward being able to collect a new Lego set or to go out to a special dinner with a relative. Where for a teenager, it may be that a teenager's curfew is dependent on what time they've left for school in the morning to make sure they got there on time, or the money that a teenager might have to go see a movie with friends might be dependent on whether or not they stay calm in interactions with the family at family dinner over the course of the week. Next, we teach parents a range of strategies to both redirect their child or teenager to give choices and to withdraw attention from a minor misbehavior that might be occurring in the moment. That's often talked about as ignoring, but it involves ignoring the behavior, not necessarily freezing out the child. And there's lots of nuance to that. One of the examples that is given in one behavioral parent training approach is of a child who is screaming at a parent about their homework, but at the same time still making good progress on the homework in fits and starts. And we talk to parents about the balance between trying to give as little attention as possible to the child's inappropriate speech, which we know might go extinct if it's not given attention, while at the same time reinforcing the child's progress on their work. Next down, we teach parents how to give clear directions and effective directions, and how to make sure to put themselves on the hook to give directions in small doses and reinforce any compliance they might see from either a child or teenager. Finally, we teach a number of rules for how to give consequences for misbehavior, what punishments look like when they're applied appropriately, and how to dispassionately apply them in small doses, sparingly and immediately when misbehavior of focus occurs. And the main thing in this case is that many of you may be saying, I wish we could go into more depth on these strategies. The books that I've recommended on the resource slide later on in the presentation do go into these strategies in more detail. And if you find a therapist who does any of the models I've cited earlier on in behavioral parent training, I can guarantee you're going to hear these kinds of strategies. Now, the last slide that I'm going to look at before I take questions is this slide, which is another slide that we look at with parents at the beginning of behavioral parent training around determining where we're going to intervene. So oftentimes with a kid with ADHD or ODD, the behaviors themselves are so vexing and so comprehensive that parents will say, I don't know where to start. There's so much to work on. What we try to do is take an incrementalized approach to certain behaviors. And the reality is with behavioral parent training, we're treating the actual symptoms of ODD. With ADHD, we're often treating the associated behaviors since the ADHD symptoms are hypothesized to be more biological. But our idea is to take a look at the child's behavior and say, what is it? How can we define it in specific and observable and measurable terms? When does it happen? Where does it take place? With whom does it happen? And what do we think is the function? Is it for the child to get some internal sensory reward, like in the sense that they really get a feeling of pleasure out of doing this activity, or control or power? Is it that they escape something they don't like? Is it that they get attention from adults or peers? Or is it they're seeking something else tangible, like they want to have access to the block set or the cars during center time, or they'd really like access to driving the car on the weekends? When we do that kind of behavioral assessment, it gives us clues as to how we might intervene effectively and how we might make sure to tailor our interventions to the behaviors that happen most frequently or that cause the most distress in the people around that child, and how we can apply the strategies I've outlined on the previous slide. So I'm going to pause there. The final slide that I was going to present just before the resource slide was a sort of general unifying concepts slide that can be really summarized by saying, remember that behavior change is gradual. It's shaped by many interactions over time. There is no one-stop magic pill for changing behavior. It's influenced by being proactive rather than reactive. And finally, behavior requires just as much support and empathy as anxiety or depression, but it inspires nowhere near the same level. And that's something we have to remember when trying to figure out how to support kids with ADHD and ODD. So now I'll try to take questions as quickly as I can.
That's a great thought, that last thought, really extraordinary, because the behavior itself results in lack of compassion, which further exacerbates the problem, right? Many of our listeners, and we found this with Attitudes readers also, find it very difficult to find a parent behavior therapist and to just figure out how to fit it into their very complicated lives, oftentimes work, and to pay for it. I know it's sort of a macro question, but do you have any advice for our readers in terms of finding a good therapist?
It is a good thing. So as you were summarizing my bio at the front, it's difficult, I think, to move through all those details right off the bat. But the title that I hold as National Programs and Outreach Senior Director here at Child Mind is focused on that exact question. Right. Our question is always, how do we get these interventions into areas that may not have these resources? How do we get them there creatively? How do we figure out how we can deliver them at low cost? I think the reality is that it starts with parents asking questions. It starts with asking school psychologists, asking friends, and asking treatment providers, what familiarity they have with any behavioral approaches to ADHD or ODD. And we boil this question down. In another webinar or presentation I did for the CDC, we boiled this down to, is your provider recommending that they're only going to see your child in session, or are they saying, I want to work with you on interventions to apply at home, and I'd like to consult with the teachers? If they're saying they want to work with the adults in the environment, they're likely engaging in some kind of approach like those that we've discussed today. If they're saying they'd like to see the child alone, that doesn't necessarily mean that they're not doing some good work with your child, or that they're not trying to engage in something that would be therapeutic or helpful. It just is not the approach that we're describing. In terms of inventive ways, one of the reasons why I list, for example, the Barkley books that I have on here and the Kasdan book is that many of the authors of behavioral parent training approaches have attempted to create accessible manuals for parents to apply this in their own homes. And what I've seen many parents across the country do is take one of these books and say to a provider, even if that provider says this is not my specialty, if they have a provider they trust, who provides other support to their family, who can help them with it, we'll encourage parents to say, take this book to your provider and say, can you wade through this with me? I know this is a crazy question, but, because lots of providers want to stay in their areas of expertise, but can you help me get a psychological lens? Because no matter what, a social worker or psychologist is likely to have more expertise with the concepts involved than perhaps someone who's in a different profession. And I think that can really be helpful. There's also, as we've discussed, a lot of web resources, a lot of webinars, and there's an increase now in places that are engaging in telehealth. And that's a question I think we often will encourage parents to go to local universities or colleges and ask if there's the possibility of either intensive treatments that happen over the summer, which there may be for kids with ADHD, oftentimes summer intensive treatment programs in certain cities. Bill Pelham down at Florida International University actually has a list on his lab's website of summer treatment programs all over the country.
Right.
And then at the same time, we'll tell parents to ask if there's the possibility of utilizing telehealth or Skype sessions for parent training, because there is some emerging literature that these approaches may be effective. And in particular, if there's nothing else, they may be the only thing. So why not try it?
Right. Are there any, in your experience, any behavior parent training programs that take place purely online? Or do you feel that having a good therapist involved in real life is critical?
I always go back on questions like this to the research literature. And the fact is that while there is research on telehealth approaches in this area, like John Comer is doing some of the research on some of the best research on kind of telehealth approaches, this is an area that is still new and emerging, and we're not sure necessarily if it's parallel effects. My general stance toward it is that there are currently practice guidelines that psychologists really have to think about related to providing telehealth in areas where the psychologist may not be licensed. That's always a consideration. And then secondly, with telehealth programs is whether or not it is equivalent when you have the option of in-person sessions. The question that you just asked me, may also involve parents who don't have the options of in-person sessions with a clinician trained in this approach. And in that case, I think we as psychologists and social workers are sort of obligated to attempt to come up with any inventive solution we can, while also making sure we're within the kind of ethical and practice guidelines and making sure that people are aware of what we do know of the research literature. Okay.
I'm going to ask this question because I think it's important for you to underscore this. Several people have said, I took my child to therapy, but he refused to get out of the car. Or another person, what do you do when a young adult will not go to counseling? So because they don't think they have a problem. I wanted to come back to the question of who is the counseling actually for? Is it really for the child?
So the thing is, with children underage, so going to kind of the two age ranges we talk about, one of the reasons why the research is sort of bifurcated or kind of diverges here is that for children under age 12, there are approaches that do not require contact with the child. So even if the child doesn't get out of the car, you can actually have an effective course of behavioral parent training where the parent or teacher or coach is just applying the interventions in the settings where they encounter the child. Now with teenagers, as we talked about, the evidence supports a multi-systemic approach which involves the child in family session or teenager in family sessions and also involves the teenager likely in sessions of their own. That doesn't mean that it's an absolute requirement in order to engage in the other, parts of a multi-systemic approach. The other thing that we think about with a teenager is trying to engage in two things. One is called motivational interviewing, which is a set of strategies that a lot of therapists will engage in that involves trying to get the teenager to tell us their goals and then trying to align therapy with the goals the teenager has. So if the teenager says, I want to get my parents off my back, I want my curfew extended, I don't want to have to come to therapy, our answer may be, great. Those are our goals too. Let's get you the curfew you want. Let's get your parents off your back, and let's make it so you don't need therapy. But let me help you do that. Let's figure out how to make it so the therapy aligns with that. And therapists engage in a lot of creative solutions to try to get a teen on that page that, may involve a phone call at first or attempting to engage the teenager over Skype just to kind of get them in the office to engage in those sessions. Another approach we've seen is therapists who focus on skills acquisition. That instead of saying to a teenager, you're coming to therapy to talk to me about your problems and so that we can process this, which a lot of teenagers are very resistant to do, it's a focus on skills acquisition. I'm going to focus on organizational skills with you. I'm going to focus on communication skills with you. I'm going to focus on emotion regulation skills with you that are going to get you what you want. That marketing to teenagers may work better. And that's something that, we try to figure out how we can collaborate with parents on.
Right. So does that suggest then that the cognitive behavior therapy and dialectical cognitive behavior therapy are not models that really should be pursued as opposed to parenting behavior therapy?
Well, the reality is that, with dialectical behavior therapy has a huge evidence base for certain, conditions and within teenage populations, particularly if we see a teenager has ADHD or ODD or now progressing into conduct problems, who also has serious difficulties with emotion regulation or coping in certain situations. We may recommend either DBT as a frontline approach or a concurrent approach. So it's not to say that DBT is the wrong approach with a particular teen. It's more that when we talk about the evidence base for ODD, DBT does not yet have a literature associated with that diagnosis just yet. And in terms of cognitive behavioral therapy, results are mixed for engaging an individual teenager in cognitive behavioral therapy around ADHD symptoms. I think the caution is first that if you engage in cognitive behavioral therapy with a teenager, you need to involve others in their life related to the generalization of the skills they're talking about in CBT. And at the same time, CBT has a real focus on thoughts and, changing thoughts, whereas with ADHD, more of a focus on skills training related to organizational skills, executive functioning, and skills that may be applied academically, or behavioral approaches are the more important components of treatment for us to focus on over and above, the kind of cognitive distortion facet of CBT. So that's why you hear the recommendations tending in a different direction.
Got it. Very interesting. So everyone, I'm afraid we're out of time. This has been so fascinating. I can't tell you how much need there is for more of what you're talking about. Thank you so much. Child Mind Institute is a fabulous resource for everyone. And we hope to have Dr. Anderson back to talk to us again in the future. Thank you so much, Dr. Anderson. Thank you, Revive, Connect.
Thanks so much, all.
And all of you for attending today. Bye.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.